Hi, you're watching Hindustan Times. I'm Aditi Prasad. The Indian Council of Medical Research has issued a new COVID testing advisory on Tuesday that actually recommends using more rapid antigen tests in the wake of the massive surge in cases that has put huge pressure on India's healthcare system. ICMR has also suggested reducing RT-PCR tests to take the load off existing laboratories. Now, meanwhile, the debate continues whether it's CT scans versus RT-PCRs versus rapid antigen tests, which tests to do and when. I'm joined by two top doctors today. Dr. M.S. Kanwar of Apollo Hospital, a renowned pulmonologist, is already here with us. Dr. Amit Thadani is going to join us shortly. I'm sorry, there is a huge problem here in Delhi. There is a storm brewing outside and I'm losing connection, but I have Dr. M.S. Kanwar with me from Apollo Hospital, who's already there with us. Dr. Kanwar, thank you for joining us. But sorry, but we have our top doctors with us, and we are going to discuss a whole range of issues regarding testing. And I'm sorry for my bad connection. I'm sorry that there's a storm brewing outside in Delhi, and there is a really bad situation out here. But I'm back now, and we have with us our two top doctors, Dr. Amit Thadani and Dr. M.S. Kanwar from Apollo Hospital, Dr. Amit Thadani from Nirmamya Hospital. There is a lot of talk. Let me start with you, Dr. Kanwar. We've seen rapid antigen tests, they having a high proportion of false negatives. They're identifying infected people as uninfected. Decisions seem to be taken. The ICMR's decision seems to be driven by two factors. One, new generation rapid antigen tests are more accurate. One, and two, of course, the greater load on existing laboratories. What's your assessment, sir?
Let me first tell you that a Cochrane review of 64 studies sometime back on rapid antigen test was done, and that was published. It showed that we'll miss a lot of cases if we just depend on the rapid antigen test. And so the yield was relatively surprisingly low, and it was not considered to be that reliable. So that means that if you are finding somebody positive, fine, take it as positive. But if somebody is negative, work on it. You might need to do an RT-PCR, do a clinical assessment. If RT-PCR is not available in that area or is being delayed and you have strong suspicion, you might even as well go for the CT scan of the chest. So these are the things which we look in. And the advantage, of course, of antigen, rapid antigen is that you can do it quickly and at a low cost and on a mass scale. It can be utilized. And the other thing is that RT-PCR pressure on RT-PCR is so huge that there is a lot of delay in the reports, anything from 2 to 7 days in different labs. And people are actually finding it difficult to even get somebody to do their RT-PCR. So that is a real, actual on-the-ground reality that the problem people are facing. So to some extent, the government's decision is justifiable because you want to, test as many people as possible. So if you want to do it quick, antigen test is fine, but then with a caveat. The caveat is very, very strong and significant. If somebody is negative, he would presume that I'm free of the disease. He is likely to infect so many more because he's probably got the freedom mentally that he's not infected. So, so that means negative cases should still be evaluated and subjected either to RT-PCR clinical examination or by whatever means by other tests, including CT scan chest.
Fair enough. Dr. Thadani, ICMR has recommended no RT-PCR test if one has completed, let's say, a 10-day home isolation period with no fever for the last 3 days. And one viewer is asking exactly that they have completed about 9 days in home isolation. Should they go in for an RT-PCR test? With what exceptions? Or should they not, according to the new advisory? Dr. Thadani, you're on mute, I think. Can you just unmute yourself and talk?
Sorry for that. So Basically, you don't need to retest. It's not required because some patients will not have any problem and they'll just keep testing positive for no reason, right? Your RT-PCR is not likely to make any difference as far as the subsequent treatment is concerned either. So what happens is that any person who has COVID will be more or less non-infective by around day 10 generally. So on the safer side, we have an additional week's isolation period, so up to 17 days. That's very much more than enough. You don't really need to retest. The infectivity is lost by the 7th to 10th day any which way. Whatever will come positive after that will be just fragments of the virus which are being flushed out by the body. So there is no point of unnecessarily doing another PCR.
So if the people are finding it increasingly hard also to get RT-PCR test done right now because of the long queues outside hospitals. What do you do? Even people who've given samples, it's taking about 4 to 5 days to come back, in which time frame their symptoms are possibly likely to worsen. What should these people do? And I want to come to you with that, Dr. Kanwar.
Yeah, this is happening. You're right, absolutely right. Now, what we do is, if the patient is symptomatic, the first thing we tell him is to isolate. You say symptoms these days of fever, a little itchy throat, and a little bit of cough. Weakness comes a little later. Tiredness, fatigue comes a little later. Sometimes chest pain, diarrhea. Diarrhea is again quite frequent these days. It was not there so frequently in the first wave of the Wuhan virus, but the mutation that we're dealing with, the double mutant or EK variations of 484 as well as 452 LR, L452L, these are the ones which are playing havoc with our lives in Delhi, in this northern region, as well as in Maharashtra. That has been found. So we might even be actually dealing with the triple mutant now, but the rapid sequencing would tell us more about that. So the symptoms have varied. You know, from time to time, a little bit of variation has come across. Sometimes they have more of your upper respiratory symptoms. Sometimes they have headaches. But there have been phases when some symptoms appeared more commonly, and later on they went to the backdrop. Not that they disappeared completely, but they were they were less commonly seen, and then some set of symptoms came in. But the overall picture tells you that you're dealing with a case of COVID. And in that case, whether there is an RT-PCR positive, or even if it has been done, it is negative, and you still suspect clinically very strongly, we isolate them, put them on the basic treatment plan.
Okay, so a lot of viewers are asking, and therefore I'm going to rephrase this. What if someone has COVID symptoms but has tested negative via RT-PCR? What should they do? Because that has been a common complaint, that RT-PCR tests are unable to catch this particular strain of the virus, and now you're talking about triple mutants, which is even more scary for me. How true is that? Or is it because of wrong, errors at the laboratory level, or are these false negatives really a reality?
I think there is a possibility that this virus has. You see, there are various things that happen with mutations. We are worried about the virus evading the tests, number one. We are also worried that the virus may not respond, the new mutants may not respond to the treatments that, whatever has been established, especially steroids, anticoagulants and stuff, or antivirals, remdesivir, those a marginal drug. So these are the things which the virus in mutations may tend to evade, may evade some tests, may also evade the vaccination. So these are the three worries. So you'll have problem in testing, in diagnosing, you'll have problem in treating, you will have even problem in saving the patients even after vaccination. That is a worry for future, because we don't know how many mutants are coming in the next few months and what might happen. But keep our fingers crossed that the virus dies its own death by going into a mutation which is a weaker mutation and doesn't proliferate much further. So coming to your question pointedly
What?
on
Yeah.
on the testing. the virus may be evading some tests because it's not only the shape of the spikes, the protein spikes on the surface of viruses gets changed in the mutations. There could be some internal changes too. So that is a possibility. But then the other possibility, as you mentioned, is that there is the kind of flooding that has happened for RT-PCR testing all over. I don't know whether they are actually doing all the tests physically or not. Even this is possible that they might be randomly not doing all the tests and giving some reports, or it is, some of the basic protocols are not being followed just to accommodate more people in a much shorter time. These are the possibilities that we might be seeing more of. We are seeing more negative tests, but when the clinical picture is clear, we go by our clinical sense. Because these days, for example, in the month of May now, there are hardly any other reasons for a fever or a cough or sore throat happening and persisting for a few days. The viral infection period is already gone. The dengue and malaria and the typhoid do not present like that. So you're left with nothing else. And then there is a contact history. Even if there is not a contact history, if there is a symptom complex like that, even if RT-PCR is negative, we strongly suspect the patient to be having COVID and go for all treatment plans and isolation in the first place.
What about, and I want to come to you with Dr. Thalani with that question. What about CT scans? A lot of patients, they are sort of, if they are getting a false negative and COVID symptoms are continuing, they are, so doing a sort of a self-diagnosis, or they are being advised to go in for CT scans. Are CT scans the answer that we are looking for?
CT scans have been used since the beginning of the COVID pandemic. Okay, Chinese were the first ones to say that CT scan is the most sensitive test as far as picking up COVID is concerned. For treatment purposes, it's very invaluable for us. However, there are certain caveats in CT scan as well. You can't do a CT scan too early in the course of the disease; it will come normal. CT scans are progressively will show progression of disease. So you do a CT scan around day 5 or day 7 if you're suspecting that the patient has lung involvement. You don't need to do a CT scan in all patients. Patients who have very mild symptoms, just the initial 2-3 days after that, they are completely asymptomatic. Those patients you need not do a CT scan. You can just continue only isolation. Any patient who is symptomatic around day 5, day 7, you should ideally do a series of blood tests. If the blood tests are suggestive or abnormal, for example, you do a CRP, it's high, you do a D-dimer, it's high. In those patients, you would be better off getting a CT test done because those patients are likely to have lung involvement as well. So CT scan also is not, foolproof in the sense you may get a completely normal picture on CT scan, but the patient may still have mild COVID.
I
But if
want
the
to.
CT is normal, essentially you would say that it's mild COVID. But again, it can progress, and the CT scan findings can become abruptly much worse within 24 to 48 hours also. So that is one thing we need to consider.
I want to go to Dr. Kanwar with that question, and because there are people who've written in to me, Dr. Kanwar, there is at the rate of Vijay Chala asking that there are some doctors, including the AIMS director, who said that one CT scan is equal to 300 to 400 chest X-rays. But the Radiologist Association is saying that it's not that dire, that it is equal to 5 to 10 X-rays. Which is correct, he's asking, and because there is a lot of confusion around people on the harmful effects of CT scan as far as testing is concerned.
Well, we do like people to be exposed to minimum radiology as much as possible. But then this is a situation where a CT scan can be very helpful. And, in very serious cases, the progression of the disease sometimes, and the disease, as Dr. Thalani said, CT scan is a progressive finding which can increase, which can stabilize, then gradually decreases. The increase can be relatively rapid, but the decrease is very slow. So at any point, you maybe day 5 or day 7, whatever be the CT score, people keep asking, my CT score is only 8. Why I'm requiring oxygen? So because it might be 8 3 days ago, it might be 14 or 15 or 13, and the need for oxygen has developed. Now, coming to the radiation, there was a time when we always believed, when CT scans came into the picture, how much exposure does a CT scan do? It used to be believed that it's about 70 to 80, 70 to 80 exposures of a chest X-ray. Now, again, CT scan, you are talking about an HRCT, and these days, if you actually have seen that this CT is done so very quickly in these cases, and the newer machines do the job so very fast and probably with much less radiation. If you do a contrast CT, then you need longer time. The exposure is much longer, many times longer. So, well, I don't know the Radiology Association's figure of five times the X-ray or 10 times the X-ray, but certainly it couldn't be too much more than that with the newer machines, which do a great job with very relatively much little exposure. Those times of 300 X-rays, they are gone, and those are with contrast CT, which is not the case in HRCTs, that the way they are being done.
All right, so it's not as doomsday a picture as has been painted.
No.
Okay. Well, and there are related questions, and I know I have limited time with you, both of you, and I understand that you have to get back to your patients. I don't want to take a lot of your time here, but our viewers are asking, and one Amresh at the rate Amresh Kumar is asking, which strain is able to escape RT-PCR? He's probably wanting to dive deeper into the aspect of strains that you were talking about escaping and the false negatives. Dr. Kanwar?
Yeah, okay. The newer strains, we are talking about the double mutant, which is B1617, which is now prevalent and probably causing more severe infections, and which is very highly transmissible also. It is what is called double mutant. And while we are talking, let me tell you, there are newer strains already in the picture, which will be published over the next few weeks or a month's time. So when I was writing the book on COVID, while we were finishing the chapter and we were giving it to publisher for printing, I had to tell him, hold on, I'm adding another paragraph because a new strain had come up. So this was happening a few months ago. So the newer strains, we do not know which ones would be evasive and how much. But this is the fear and the suspicion that the more, for example, the strain in South Africa, that was, believed to be more virulent and also escaping the testing. While the Brazilian strain was not considered to be that bad, even the UK strain was not considered to be that bad. But probably the double mutant that we are facing now is the worst of them all. And if the storyline is true about the triple mutant or double mutant is where in the same virus that two mutations have happened at the same time, or three mutations have happened in the same time. So that changes shape. So that has a greater tendency to evade all the three things which I mentioned earlier.
Okay, let me come to you. Let me quickly take some viewers' questions, Dr. Thadani. Can somebody's asking Mohit Kumar Vashisht? My father had milk symptoms in CT scan. I don't know what that is. He's in home isolation. Does he need CT scan again?
See, it all depends. If a CT scan has been already done once, it can be needed again, provided the patient has ongoing symptoms. If a person has cough, fever, continuing at around day 5, day 6, day 7, or if it has completely disappeared and then it suddenly starts again, those patients you must do a repeat CT to find out what is going on. Otherwise, if the symptoms are completely absent, you need not actually do it. If the symptoms do not appear, do not reappear, patient is otherwise absolutely asymptomatic, I don't think there's any need to. Otherwise, if any fresh onset of symptoms or any worsening of symptoms or any drop in the oxygen saturation, which usually will be accompanied with some symptoms, it just doesn't drop like that without anything at all. So these are the times when you would want to do a repeat CT scan. Otherwise, for an asymptomatic person or very mild symptoms which have disappeared by day 3, day 4, in those cases, you really don't need to repeat a CT scan as such. In fact, you wouldn't need to do a CT scan upfront as well.
Okay. At the rate Tripura BOI is asking, and Dr. Kanwar, I was infected by COVID 5 months ago, but after 5 months, I feel pain. Pain again, not so much. What should I do? Should I do a CT scan or a chest X-ray? Which one?
Oh, uh, you said there's a chest
She,
pain?
yes. 5 months ago, she was infected by COVID.
Yeah.
She's feeling not much, but little pain in the chest. And
Okay.
what should
Pain in
she
the
do?
pain in the chest could be due to a whole lot of reasons. It could be muscular. It could be in the rib cage. It could
So
be
basically,
inside
see your
in
local
the
doctor.
pleural area.
See,
It could be, yeah. It could be so many things. So let's not think of COVID straight away if there is a chest pain.
right.
So it has to be established what is the reason for
So
that. First of
right.
all,
So approach
that is
your
to
local
answer that. Yeah.
doctor. Approach your local doctor at the rate Tripura POI. That's what Dr. Kanwar is advising here. What should mild symptoms patients need to do once they've recovered? Since this time there are news about increased heart attacks in recovered patients, and that's at the rate of Aman Sharma asking. Dr. Kanwar, I can come to you with this question.
Okay. All right. Look, in the beginning, when COVID came into the picture, that was around the month of April or May, when the reports started pouring in with myocarditis. And subsequently, the autopsy findings side by side were also showing that there were a lot of clotting happening in the blood vessels, including the coronary vessels. Now, that was, in fact, one of the major reasons for death and also the major reason for persistent hypoxia, persistent fall in oxygen level, which was not improving. Now,
Okay.
when we know that there are two things which are happening, inflammation and clotting, then we have to take care of both of them, which we do all the time simultaneously. Now, in a situation where there is a chest pain, it could be myocarditis due to inflammation of the myocardium, means endomyocardium or myocardium, the heart muscle. If it is inflamed, usually it is inflamed locally, not generalized. The pain can be due to that. The pain can also be due to the clotting or blockage of the coronary vessels, which can lead to heart attack. There have been many cases, we have faced it ourselves, where the patient was getting well, the oxygen level was coming down, in fact, had even gone off oxygen, and the patient suddenly crashed with changes of acute MI, myocardial infarction, where the ejection fraction came down, troponin I was jumping up. So all these things happen due to the clotting mechanism, which is highly activated in this disease.
My God, I'm flooded with questions, sir. And while you were talking, I was just looking, and I think a lot of people are tuning in, and a lot of people want to know a lot of. They ask. Somebody's asking. Krishna Indu Das is asking, what are the symptoms of an asymptomatic patient? Well, you are asymptomatic, so there are going to be no symptoms, Krishna Indu Das. So that's the whole point of being asymptomatic. Dipan Joshi is asking, are the mutants moving much faster than our understanding of them and of treatment plans? Is this triple mutant that Dr. Kanwar you were talking about going to be worse than this particular strain which is there?
Let us hope and pray not, because we have had enough. And the way we are fighting this COVID mutation, the current COVID mutation at this time, it's difficult to describe how we are handling them in our hospitals. It is difficult to describe. Mutations. Let us pray that mutations eventually go into a direction where the virus becomes weak and dies its own death. You cannot kill the virus. Let me tell you that. we do not have the medicines to treat the virus in a way that we can treat hundreds of other diseases. So, and virus is far ahead of us. Whatever our science is doing, whatever vaccination we're doing, if suppose the newer mutants stop, they start bypassing the vaccine, then all the effort put in for the last year, more than a year, for vaccine manufacturing would be a waste. Let's not think of that, because that is a scenario which is a possibility. Scientists know that that is a distinct possibility. It might happen one day, or at least partial evasion is already believed may be happening in some mutations. So it is too unpredictable to say now what might happen in future, but this is a distinct possibility. And the newer mutations, the one direction is that it will die its own death, but so far it is not happening like that. So far, the newer mutations are more transmissible as well as more virulent. That is why the disease has changed its course. It used to be first week of the disease, second week, now the disease is in the lungs. Now the oxygen has started to fall. My dear, the oxygen is falling now on day 3, day 4, day 5. The oxygen, and by day 4, the patient may be already at the hospital with oxygen, on oxygen.
Absolutely.
So the scenario has changed. So what might happen in future is very difficult to say, and one should not try to predict things, because all the predictions in COVID disease of all kinds have fallen flat. They have been way away from reality.
So I want to ask you your closing thoughts, and I have one more question. But before that, I want to take one question with Dr. Thadani, and because somebody is asking, if I get my, if I've already recovered from COVID, do I need to take the vaccine? And if yes, how long should I wait for the vaccine? So the answer to question number one, I can give you. I'm a partial expert. Yes, you need to take the vaccine, but even if you've recovered from COVID, but I'll leave the duration for Dr. Thadani to answer.
So the recommended duration is 3 months, but generally it is considered that even after 1 month you can take it. In some countries, it has been given as early as 2 weeks after recovery from COVID. But generally, I will say that at least we should wait for a month. Generally it's 3 months.
Wait for 3 months before getting your vaccine if you have already recovered. Yes.
The reason why CDC gave this 3-month figure was very clear, because the disease that you have just got out of, it would produce immunity which would last in any case 5 to 7 months, probably longer, certainly not less than 3 months. So why waste the duration of the vaccine by giving it much earlier and trying to build up your antibodies to much higher levels when it is not really required? So there was a good logic when CDC gave this 3-month figure. So 3 months, because your initial immunity would last hopefully 5 to 7 months at least.
All right, great. Thank you so much. And before I let you go, sir, I want to ask you a question. And which test is most effective and affordable, and why? Because I knew I'll only take you for. I will only keep you here till 6:30. I've already exceeded the time by 3 minutes. But given the new testing guidelines given by ICMR, and given my electricity problem and my connection problem at the beginning, so I did not get to hear your answer completely. Which test there is? Rapid antigen, there is RT-PCR, and of course there are CT scans. If I am having symptoms, which test should I go for at first, most effective and affordable, and why?
You want me to answer?
Yes, Dr. Kanwar, yes.
Okay, all right, RT-PCR, because it's most reliable, the gold standard, and whatever be the constraints that it's right now, there's a lot of strain on the labs. They are not taking the samples, not accepting samples, or taking much longer. But yet, RT-PCR is the gold standard, because if I do only rapid antigen test, I'm still not sure if it is negative whether the patient is getting the disease or not. and CT scan would not be my first choice.
Okay, CT scan would not be your first choice. Rapid antigen, not first choice. RT-PCR, the gold standard, is the way to go. And you're saying this despite what ICMR's new guidelines are, encouraging people to go more for rapid antigens as opposed to RT-PCRs. Dr. Thadani, your views on that?
So, in a situation where you can't get an RT-PCR done for 4 days, 5 days, it's better at least to have some test in hand. Right? Rapid antigen is a low sensitivity test. We all know that. But if a rapid antigen is positive, it is positive, and that's the end of the story. You don't need to repeat a PCR to check it again. Okay. So if you get a rapid antigen positive, that's it. You don't need to do a PCR. So in that context, it's still a useful test. Uh, the sensitivity, of course, is a problem. There are a lot of false negatives, but of course, you get the report in 10 minutes. So there are advantages to rapid antigen. If in a situation where you can't get tests done, at least you
Right.
have, even if it is negative,
Something
symptomatic,
is better than
something is
something
better
is
than
better
that. And
nothing.
if you're
Absolutely.
symptomatic, the chances of you testing positive on rapid antigen are not bad. In that, you know.
All right. At this point, I'm going to ask Dr. Thadani to stay back a little more. And I know, Dr. Kanwar, that you have another meeting lined up. So if you want to leave, because there are some questions that are still pouring in, and I'll be happy to have Dr. Thadani answer them if you can stay back for a little more time.
Another 5-7 minutes is fine. Yeah.
All right.
Because my
So just
patient, it would be starting at 6:45. Yeah.
lovely, sir. So another 10 minutes of your time. Great. Thank you for staying with us.
I knew
There-
I knew your electricity will give you trouble, so I gave them 10 extra minutes.
Thank you so much, sir. Thank you. Uh, Again, a lot of repetitive questions coming in, but so I think you've already answered them. But there are some that are very interesting. At the rate Sachin Tripathi is asking why, in some cases, CT value 11 by 25, people are dying in the hospital, and in some cases, people are recovering even at home with an 18 by 25 score at home in home isolation. And he's saying that 3 cases from my nearest one. That's a question, Dr. Kanwar. Would you like to take it?
Uh, the patient's response is one issue here. The other issue is the uh, the severity of the patient's disease. Now, what we are seeing in the CT scan is only the picture in the lungs. We are not knowing the picture in the rest of the body. While the rest of the body, probably through the tests like CRPs or IL-6 or D dimers, or in older age group, even troponins. So all these things can help us know where we stand. So collective data on these things can sometimes, give us a reasonable indication which patient is going to go down, which patient is going to remain stable, and then your lungs, how do they handle that onslaught that has happened, which is showing up as 18 or 17. Let me bring you another point here. These 17s and 18s and 12s and 13s, I have seen the CT scans myself. I don't know who's reporting these days in several labs. The results, the reportings are not correct. And if it is 18, and when I see it, I think it is 13. And that's why the patient is behaving like 13. So there are lots of ifs and buts here.
Okay.
So that's why whenever the patient is nearby, I ask them to bring the CT scans to me whenever I'm in doubt. And these days, I'm in doubt a lot of times.
All right. There are some people asking, are CT scans really harmful, etc. I would urge them, probably you've just joined the sessions, our doctors have answered that. So please do go back, and once our broadcast is over, do go back or just go back, rewind a little, and we'll get their take on that. There is an interesting question, and she's asking again and again. So I'm going to take this question. Can we do the at the rate MH3, no, not at the rate, MH03 India is asking, can we do the COVID treatment at home for patients who are having symptoms like high fever, cold, body pain, headache, and feeling low oxygen in body, when what I think she's asking is, when she has a COVID patient at home, when is the time to take that patient to hospital and stop home isolation? And I'll come to you,
Let,
Dr. Thadani, with that first.
all right,
Sorry,
all right.
I'll come. Let me ask Dr. Thadani, then I'll come to you.
Okay, I thought I'll just answer a couple of questions and leave.
Okay, all
So
right, all right.
then you
Please,
can direct the rest of the questions to Dr.
all right,
Thadani.
please, Dr.
All
Kanwar.
right,
Thank you so much.
all
I think
right.
your inclination
Uh,
to reach out to all the viewers and try and answer
no, what
those
I'm saying
is
is so that
heartwarming.
then
Yes,
you can
please.
take another 10 minutes with Dr. 15 minutes to Dr. Thadani if is there. All right.
Sure.
So patients who are dropping their oxygen is one sure indication that he should not be treated at home. That is one sure indication. Fever, even if it is persisting, uh, as long as the oxygen is stable, nothing to worry. The other reason why the patient might need hospitalization is if he is vomiting, retching, and is not able to tolerate the drugs that you want to give. You want to give them oral steroids, for example, and if the gastric intolerance is there and he is not able to accept it, then that is another indication. If the patient is dehydrated, is not taking anything orally, you might give IV fluids. You see, three things I warn people about, and I would like to tell everybody three things that you should be careful about is saturation falling below 95%, and in older individual also falling below 94% or 90 maximum 95%. And number two, somebody who's having breathlessness on exertion or at rest. Number three, persistent high-grade fever. These are the three things which I tell them to be watchful about, because that is where we escalate our treatment. If the fever is persistent for several days and it's not coming down, that is also an indication for escalating the treatment. But otherwise, for going to the hospital, oxygen and oxygen is the most important thing. If it is falling, let's say if it has already fallen to about 92, you're watchful. You have to be ready that next thing could be going to the hospital. But these days people have concentrators at home, they have oxygen cylinders at home, so they somehow don't get any beds anywhere. Even nearby NCR, they're not getting beds. So we keep treating them at home with steroids and anticoagulants. And some people have even had remdesivir at home with the help of the nurses or the home care people. So that is what goes on. But low oxygen or falling oxygen, even at borderline, means in this disease, it can go down suck like that. The trouble with this disease is, especially this newer mutant, is that it can lower the oxygen very rapidly. In the morning, the saturation is 90%, and the oxygen requirement is 1 liter. By evening, it is 6 liters. By night, it is 15 liters. That is the kind of cases we are seeing in Apollo Hospital. I mean, we have almost 500 patients admitted right now, and more than half, in fact, 70% are on oxygen.
All right. Okay. I hope that answers your question, MH03 India. Ria John is asking that should the test be done again after 14 days of quarantine? Ria, I think that completely depends on your condition, and the ICMR has now said that you cannot. But Dr. Kanwar, if you want to take that question, she's been in.
Oh, sorry. You
14
said what?
days.
Should we repeat the test?
Should she repeat the test? She's been in isolation for 14 days. And now should she repeat the test?
Dr. Thadani answered this question in the beginning, that it is not really essential, but those people who would go to their offices, there is this condition that they have to show a negative RT-PCR, otherwise they cannot join. And for healthcare workers, absolutely essential that they have to have an RT-PCR before they join. But 17 days isolation period maximum is what was considered a right decision last year, and I stick to that even now, because in severe cases, the infectivity can go on beyond 10 days. There was a study from Singapore last year which showed that up to 11 days, usually up to 9 to 10 days, but maximum 11 days is the time when you could infect others. Thereafter, it's a dead bacilli, a dead virus, which might be excreted and may not cause the disease. But then there were reports subsequently, and we felt that patients continue to be sick patients who are in the ICU. They continue to be positive, sometimes much longer. I mean, 3-4 weeks. We have even seen 5 weeks. So those people probably could be infected much longer. So 17 days was a safer period, so that you don't take any chance with anybody infecting anybody for even a day or two.
Thank you so much, Dr. Kanwar. I think it's 6:45. I'm also worried about your patient that you have to go and
Thank
see.
you.
But thank you for joining us,
Thanks.
Dr. Tharani. Yes, thank you, sir. Dr. Tharani, I want to ask you, there are one or two other questions, but I hope I'm not detaining you longer than I also told you half an hour. But let me just take one question and then let it rest at that. And this is in continuation to the question which was asked by Dr. Kanwar earlier, to Dr. Kanwar earlier. If a patient's normal baseline is around 94 or 95 and he is 81 years old, what should be the cutoff for taking the patient to the hospital?
There are some patients whose baseline saturation is around 94, 95, and it will not show a drop. If there is a drop below that normal level, then it needs to be taken seriously. Even a drop of, if it comes to 92, 93, it should be taken seriously. So, any dip in saturation from the patient's baseline must be taken seriously at any time. So, we can
Or
consider that a normal saturation is above 95 generally. Anything lower than normal, you must investigate and get treatment done.
all right. Given the pressure on our testing system, Dr. Thadani, right now, there has been talk of over-the-counter testing kits for COVID, and which are in use in several countries, developed countries. Do you think we could look at a possibility of their use here in India, or what is the hiccup there?
If you want an accurate count of the numbers all the time, then obviously that is not going to help you. If you're fine with people getting diagnosed and treated, then it's a perfectly legit thing to do. You should have testing kits available. So it all boils down to what is the objective. The objective is, I believe the objective should be to diagnose and treat. If the
Absolutely.
objective is diagnose and treat rather than just build on the numbers, then you should have no problem with people testing themselves and taking necessary action. But then you don't know how people are going to respond, whether they will isolate, who will be the concerned authorities, who would detain. In a situation like maybe Delhi, where you can say literally everyone is around is infected, it really doesn't make sense for delaying tests and delaying everything, and because everyone around is infected anyway, right? So the load in the environment is so high. So in
Hmm.
that sense, it makes perfect sense to allow tests like this. But if you're in a remote area and where you would preferably want to diagnose every single case because that community is not actively infected yet, in those situations, definitely it makes sense for the government to have every single case data. Where we are now, in the places where the disease has already exploded big time, I don't see any reason why we should, chase numbers in those places. It's better to have a diagnostic test which is freely available, which you can do and treat. So,
All right.
yeah,
And so you believe that the government should make efforts to get over-the-counter testing kits here so that the pressure on our laboratories can be eased, people can be diagnosed and treated on time and are able to recover from the coronavirus on time. And for all those people who are still sending in questions, I'm sorry, the time period for today's show is over. Please do join us tomorrow at 6 o'clock. Please send in your questions on HT tweets. Or you can write on this on whichever platform you're viewing this, on Facebook, on YouTube, in the comments box. Keep putting your questions there. We will take them up tomorrow, and we will come back to you with more information with our doctors tomorrow. While India is still, of course, reeling under the second COVID wave, the principal scientific advisor to the government, K. Vijay Raghavan, has already said that a third wave is inevitable. Experts are of the opinion that the third wave may affect children adversely. What we need to be is better prepared, even if that means over-the-counter COVID test kits. Ramp up our healthcare system, ramp up our testing capability, and of course, our vaccine availability and delivery. Thank you, sir, for joining us. Thank you, Dr. Sadani. In the meantime, for all our viewers, stay safe, stay tuned to Hindustan Times, and don't forget to join us at 6 p.m. tomorrow for another session with our doctors. Thank you, sir.